obstructive jaundice. Though it is per se a disease of hepatobiliary system, but basically it has multisystemic anesthetic implications and it poses multiple challenges to anesthesiologists whenever such cases are posted for various surgeries. As we all know, liver is the most second largest organ and the most vascular organ. It receives 30% of the cardiac output and it has various important functions to play. Anatomy itself is very peculiar. There is a coineate system of arrangement of lobes. There is a liver lobule which has an hexagonal structure. Liver acinus, which has three zones, periportal, midzonal, and central. Every zone has its own peculiar functions. Hepatic blood supply itself is a peculiar one. It is a dual supply. 25% received from population and 25% from systemic hepatic circulation. And definitely, oxygen delivery will be also shared by both the dual supplies. It forms this rich vascular sinusoidal bed in the liver parenchyma, which accommodates around 500 ml of blood. Why we are talking about hepatic blood flow? Because the entire dynamics of hepatic blood flow affects our anesthetic management. Hepatic blood flow is regulated by intrinsic mechanisms as well as extrinsic mechanisms. There is a significant autoregulation which controls the hepatic blood flow. Various responses like anesthesia response, portal cirrhosis, portal hypertension, systemic vascular response, hepatic arterial pressures, they affect hepatic blood flow directly. Plus, there is a peculiar hepatic arterial buffer response, which has a capacity of doubling the hepatic arterial blood flow if the situation arises. But again, sepsis, pathologies, liver cirrhosis, anesthesia responses, various drugs, systemic inflammatory responses affect the hepatic buffer response. And if it is affected, hepatic blood flow is hampered. Then there are metabolic factors which also affect hepatic blood flow. So if there is severe acidosis, there will be hampered hepatic blood. There are certain extrinsic factors like sepsis, infections, sympathetic responses, hormonal imbalances, which increase the hepatic blood. At the same time, hypoxia, hypercapnia, hypocapnia, cirrhosis of liver, postural variations, anesthetic drugs, they decrease the hepatic blood. So we should understand the entire dynamics of hepatic blood flow, because whenever we are managing these cases, we have to keep in mind that we have to maintain this hepatic blood flow dynamics so as to improve the perioperative outcomes in the cases of liver. One should know the functions of liver. It is very important organ. It has blood reservoir function. It affects metabolic functions like glucose metabolism, gluconeogenesis, and glycogenolysis occurs at liver. Lipoprotein metabolism is happening in liver. Hepatocyte is responsible for ketone metabolism. Protein synthesis, it synthesizes various important plasma proteins, coagulation factors, urea synthesis, amino acids, enzymes, hormones, etc. Drug metabolism, xenobiotics, it's an organ of xenobiotics, conjugation, ester hydrolysis, phase 1 and 2 reactions. It is a site for bilirubin formation and excretion and entire biliary system metabolism. Immune function is one of the important functions of liver. It has antibacterial properties. Coagulation pathway is directly affected by liver metabolism and various clotting factors are synthesized. If enterohepatic circulation is affected, there may be deficiency of fat-soluble vitamins, which again affects coagulation pathways. Fibrinogen synthesis, platelet function, plasma proteins, again, are affected by liver dynamics. And the most important function of anesthesia importance is the drug clearance. There are two types of eliminations, capacity limited and perfusion limited. In capacity limited elimination, the drug extraction ratio is lower and clearance decreases if drug extraction ratio is decreased. So it depends upon microsomal enzymes, protein binding, and liver conjugation pathways. There is another perfusion limited elimination, which depends directly upon hepatic blood flow. So if the drug is having high drug extraction ratio, there will be rapid clearance. So if hepatic blood flow is hampered, there will be decreased elimination. For example, for opioids, for lignocaine, for beta blockers, for other tricyclic antidepressants, and so on. And in capacity limited conditions, for example, benzodiazepine, pentothal, pancuronium, and other warfarin, these drugs directly depend upon microsomal enzymes and protein binding. So whenever there is chronic liver disease, whenever there is parenchymal damage, the drug metabolism will be decreased There will be cumulative effect to the drugs, and ultimately there will be decreased clearance. One should also know about the biliary system, some anatomical peculiarities. Now, bile flows from hepatocytes to the canaliculi, to the bile duct, to the hepatic duct, then CBD, then reaches up to the duodenum. So, anywhere in this pathway, if there is mechanical obstruction, this will cause obstructive jaundice. A word about bilirubin metabolism. As I already told, that whenever there is bile in the circulation, it is unconjugated. It combines with protein, albumin, and then it transfers into the hepatic sinusoids. In the hepatocytes, it is conjugated, and this conjugated bilirubin enters the biliary system. It reaches up to the small intestine. In the enterohepatic circulation, it is converted into urobilinogen, and then it is converted to stercobilinogen and is excreted in feces. Some amount enters the portal circulation and then excreted through kidneys in the form of urobilinogen. So again, obstruction anywhere will lead to predominant conjugated hyperbilirubinemia and will lead to obstructive jaundice. Anesthesiologist also should have an idea about liver function test, because when we do the pre-anesthetic checkup in these liver cases, we should know how to interpret these functions. So there are certain non-specific functions which give us an idea about hepatocyte function, like enzymes, aspartate transaminase, alanine transaminase. Alanine transaminase is more specific for hepatocyte because alanine pyruvate cycle, hepatocyte is a site for that. So alanine pyruvate conversion is affected. So alanine transaminase will be elevated. Other LDH and glutathione S transferase are again non-specific indicators of hepatocyte function. There are sensitive parameters which give us an idea about synthetic function of liver, like plasma proteins, albumin globulin ratio, serum albumin levels, PT INR, and etc. Secretory function can be assessed by bilirubin levels. In obstructive jaundice, there will be predominant conjugated hyperbilirubinemia. Alkaline phosphatase will be elevated. 5-nucleotidase will be elevated. Gamma glutamyl transferases will be elevated. There are certain imaging techniques which tell us about the obstruction, about the cholestasis, whether there is intrahepatic cholestasis or extrahepatic cholestasis, like intravenous cholangiopancreatographic studies. Also, there are DART studies, bromosulphthalene excretion studies, but they are less popular. But we should have an idea about how to interpret these results if we receive the patient pre-anesthetic checkup. Coming to the topic of today, obstructive jaundice. Now, there are various causes of obstruction. As I told that anywhere in this biliary system, if the obstruction is there, it can be benign, like there are gallstones, there are strictures, there are choledochal cysts, biliary atrasias, some parasitic infections, which can lead to extrahepatic cause of obstructive jaundice. Then there are malignant causes also, like CA pancreas, ampulla of Vater, biliary duct carcinoma, and then we have gallbladder carcinoma. There are intrahepatic causes like familial hereditary disorders, cirrhosis of liver, acquired causes like drugs, viral hepatitis, alcoholic cirrhosis, sclerosing cholangitis, etc. So ultimately, there are various causes of obstructive jaundice. And anytime these patients can be posted for any surgery with us. We should know what are the signs and symptoms. Broadly, there is progressive jaundice, dark colored urine due to urobilinogen, clay colored stools due to stercobilinogen, fever, chills, rigors due to cholangitis component, pruritus again due to bile salts deposition and bile acid deposition. There is definitely predominantly conjugated hyperbilirubinemia. Enzyme transaminases are elevated. Alkaline phosphatase is elevated. Pathophysiology is related to back pressure dynamics. There is bile duct pressure which is decreased due to decreased bile flow, and ultimately there is obstruction. Cholestasis has widespread effects. It causes hampered hepatocellular and synthetic function. It has systemic effects on CVS, RS, renal, and gastrointestinal system. It develops malabsorption syndromes. There are deficiency of fat-soluble dependent vitamins like A, D, E, K. And due to hampered enterohepatic circulation, there is ammonia toxicity and ultimately endotoxemia due to metabolites. So these systemic effects pose challenge for us. In chronic conditions, if there is long-standing disease, the total hepatic blood flow is hampered and there is increased portal pressures. So portal hypertension is associated with this. Bilirubin and other toxic products have direct cardiodepressant effects. So there are chances of bradycardia, impaired cardiac contractility, autonomic imbalances. There is decreased peripheral vascular resistance and exaggerated hypotensive responses. On the renal system, there are chances of direct bilirubin toxicity. like acute tubular necrosis and endotoxemia. Immune system is affected as liver is a center for immune-mediated defense mechanisms. So complement cascade is affected. There is defective cellular immunity and there is depressed reticular endothelial system. Coagulation pathways are deranged. There may be hypercoagulable states. Patients may be in DIC also if their disease is too advanced. Wound healing is hampered. So surgical site infections are very common in such patients. And definitely there is endotoxemia due to enterohepatic circulation compromise. So all these systemic challenges, systemic effects affect our anesthesia management. So anesthetic implications are tri-radiate. Number one, due to liver dysfunction. There are chances of low serum proteins, coagulopathy, drug metabolism alterations, metabolic disturbances like hypoglycemia due to glycogen storage depletions, electrolyte imbalances, acidosis, hematological compromise, maybe patient may be in DIC, deficiency of fat soluble vitamins, and there are altered lipid profile metabolic alterations. Secondly, there are systemic effects of bilirubin. As I already told, that there is cardiorespiratory collapse or compromise. There is depressant effects of bilirubin and other toxic products. There are chances of hepatorenal syndrome, hepatopulmonary syndrome. These patients are vulnerable to infections due to low immunity. And many times, if untreated, they can land up in hepatic encephalopathy. Thirdly, there are surgical factors which pose challenge for us because all these patients are posted for major surgeries, Whipple's surgery, laparoscopic surgeries. Nowadays, we are doing robotic Whipples. So they are associated with major fluid shifts, electrolyte imbalances, again, hemodynamic fluctuations. Due to multisystemic involvement, we have hemodynamic fluctuations. Duration of surgery is very long. There are big incisions if it is open surgery. Anyhow, if these patients are even posted for minor surgeries, like some biopsies or some minimally invasive procedure, or even for ERCP, every procedure has its own different challenges, which are superimposed on the basic pathology of obstructive jaundice. So ultimately, our anesthesia implications are too many, and we have to tackle them. So we have to assess the risk. We have to stratify the risk. We can optimize the patients accordingly. What are the additional risk factors? In obstructive jaundice, if the extremes of ages, they pose the additional risk. The associated comorbidities, they trouble us additionally. Like these patients may be diabetic, these patients may be IHD patients, these patients may be old age, extremes of ages, and various other diseases these patients may be having suffering from, additional with the obstructive jaundice. Now, duration of disease, as it prolongs, it has its own implications because prolonged liver damages develop the signs of hepatic failure, and ultimately we will face different problems. Nutritionally, these patients are very poor. The third space losses are high. The volume of distribution is contracted in these patients. So they have a contracted volume depleted state, basically, and they have intracellular dehydration. So long-standing disease with nutritional impairment, again, will add to our problems. Renal and metabolic status is already deranged. Many patients directly will be coming in hepatorenal failure states. We will have to deal with them. So what we should stratify and what should be our objectives? We should assess the type and degree of liver function. We should assess that how liver is affected. How are the other systems? What is the pattern of the disease? We should judge the synthetic ability of liver, how liver is stronger, or whether it has weakened to such a level that we cannot recover it. We should assess the general condition also. And finally, we should optimize these patients before posting them for major surgeries. So we have various guidelines, we have various classifications. Ultimately, thorough pre-anesthetic checkup is a mainstay. So to assess, we have to do entire systemic assessment, and we can use these classifications, these Child-Turcotte books classification, which give us an idea about the severity of the disease and have a prognostic importance. This Child-Turcotte's book classification relies on 5 parameters, and it has a scoring system. Marks are given on encephalopathy, ascites, bilirubin levels, albumin levels, prothrombin time, INR, and ultimately the scoring system is there. And if the score is 5 to 6 points, it's a least severe disease. If it is 7 to 9 points, there is moderate severity. And if it is more than 10, the severity is very high. There is another scoring system, which is MELD score, Model of End Stage Liver Disease Score, which considers bilirubin levels, INR levels, serum creatinine levels, and a liver constant. And it has a formula. And it also considers that whether patient is on dialysis or not. So accordingly, it gives us the scoring system. There is modification to this MELD score now. Sometimes it considers sodium levels, specifically in patients of hepatorenal failures. So MELD sodium is another scoring system, which gives us an idea about the renal condition also. Then there is delta MELD, which is a difference between current MELD and the lowest MELD 30 days prior. So it will give us an idea about how the disease has progressed. If this delta MELD is higher, means the disease has worsened. There is MELD integrated, which is given in recent Miller. MELD integrated includes age also. So elderly patient will have higher MELD scores along with INR, bilirubin levels, creatinine levels, and sodium levels. So basically, these all scoring systems are there, which will assess the liver dysfunction, that how liver is damaged and how severe is the disease. Other assessment principles, we have to check how is the cardiovascular system, how is the renal system, what are PFTs. We can advise 2D echo. We have to advise ECG. We have to see for radiological imaging to check for the other systems. To know the pattern of disease, we can go for enzymes. We can do diagnostic ERCPs. Sometimes biliary studies are done. Sometimes what happens, there is a too much biliary load and bilirubin levels are more than 30. So to optimize them, we can do the therapeutic MRCP or ERCP, and we can put the stent for drainage of biliary system. So this will decrease the biliary load. We have to judge the synthetic ability of liver. So we have to check for protein synthesis, albumin globulin ratio, PT-INR, coagulation studies we can do. We can check for clotting factor assays to check the coagulation system. To assess the general condition, we can go for all the other basic routine investigations like electrolyte, hematological assessment, hepatic imaging we can do microbiological assessment. So ultimately, our thorough pre-anesthetic checkup will help us in managing these patients and will definitely have an impact on successful perioperative outcome. So ultimately, this all will help us in optimizing the. So what are the principles of optimizing these patients? Now, suppose this patient is having a parenchymal damage. It is long-standing obstructive jaundice, but is posted for Whipple surgery now due to malignancy if the cause is malignancy. So we will have to have certain principles. In our institute, what we follow, we concentrate on hydration principles. We admit the patient. Generally, these patients are already kept in ICUs, in pre-anesthetic rooms or in pre-operative ICUs. So we hydrate them. We use crystalloids. Nowadays, we are using balanced salt solutions. We can use colloids also. But again, there are two schools of thought because colloids have impaired effect on impaired coagulation and they have their own renal impairment effects. But we can use hexastarch if we want to use. We give vitamin K 3 days prior, and then we transfuse the patient with FFP. Generally, what we follow on early morning, 4 a.m., we start FFP. At least 4 units of FFP, we transfuse them before the surgery. So at the time of reaching up to the operation theater, patient has already received FFP. We give higher antibiotic cover because these patients have chances of endotoxemia. We concentrate on nutritional buildup. So there are hepatic friendly TPN formulae available nowadays, which have limited lactate levels. Calcium levels are also in the limited levels in those formulae. So they have less hepatotoxic effects and they improve the nutritional status remarkably. So from 24 hours prior to the surgery, we start these nutritional formulae. We transfuse them with FFP. We start vitamin K and we hydrate them with balanced salt solutions. Few companies are providing balanced salt solutions. So we are using their products. In cases where bilirubin level is already more than 30, as I've already told, we are doing biliary drainage procedures. We are requesting surgeon to do therapeutic ERCPs or MRCPs and we are putting stent in them so that bilirubin levels are decreased. We give them neomycin and polymyxin cover again to maintain the enterohepatic circulation to avoid endotoxemias. IV mannitol, some people are preferring, but again, there are controversies related to that because IV mannitol, what it causes osmotic diuresis and ultimately it causes intracellular dehydration, which will worsen the problem in some cases. So there are two schools of thought related to that. We should set up certain goals. So we should have anesthetic management principles clear in our minds, managing these cases. We cannot afford more additional insult to liver and kidney. We have to preserve the kidney function. We have to preserve the remaining liver function, which is already there is a parenchymal damage. We don't want to do the additional harm. We have to maintain oxygen supply demand ratio. We have to maintain eucapnia. Ventilatory strategies are very important. We should avoid larger tidal volumes. We should avoid hypoxias and hypercapnias. And we also don't want hypocapnias at the same time. So electrolyte imbalances we don't want. Renal perfusion is of utmost prior importance. We don't want any sympathetic drive, any hemodynamic fluctuations, hypotensions, remarkable fluctuations in the hemodynamics, which will affect the renal perfusion. We cannot afford decreased renal blood flow. Already we have to preserve hepatic blood flow. The choice of drugs, anesthetic drugs, again should be very meticulous, because if we don't titrate our anesthesia management, we will lose that delicate hepatic flow dynamics, and we will lose that hepatic arterial buffer as well. And if hepatic blood flow is decreased, it will be a vicious cycle. More drugs will be accumulated, more delayed recovery, and ultimately we will land up in various complications. We should achieve optimum perioperative analgesia, because again, pain will be a sympathetic overactivity. So what should be our technique? Ideally, what we follow, any intramuscular injections, because there may be coagulopathy. We avoid diazepams. We can give midazolam. Overnight sedation, generally we are using oral diazepams. They are better tolerable and they are safely as far as hepatic enzymes metabolism is concerned. But again, some patients have already landed up in hepatic encephalopathy grade 1 or so we avoid them. We have to give good antacid and antiemetic prophylaxis. In our institute, we are following pantoprazole, of course, and also we are following palonosetron. We are avoiding granisetron because granisetron is hepatotoxic. Ondansetron is good, but it has a low potency. So in our institute, if major cases there, we are giving palonosetron as an antiemetic prophylaxis. And single dose suffices. It has a duration of 24 hours, so we are free for 24 hours as far as anti-emesis is concerned. Monitoring. Now, ours is a tertiary institute. We use all types of advanced gadgets and advanced monitoring. Apart from minimal mandatory monitoring, we are using invasive arterial lines, central lines. We are doing ABGs. We are using most care monitor. That is a non-invasive cardiac monitor. We are using bioreactance principle also. And we are using neuromuscular monitor. TOF monitor we are using. But in smaller nursing homes, in medium nursing homes, if monitoring this type of array of monitors is not available, I would recommend at least basic minimum mandatory monitoring along with central line, arterial line, temperature monitoring, and ABG should be there with us. At least this much we have to follow. Neuromuscular monitoring, if it is available, it is a very good thing. And other advanced monitors we can think of. We don't have thromboelastography, but in books, it is recommended. If patient is in early DIC, we have to do thromboelastographic assay. But in our institute, it is not available. So that is also recommended as far as books are concerned. So all the advanced monitoring we should adopt ideally in ideal situation. What should be our drug choice? There should be optimum pre-oxygenation because these patients have already compromised cardiorespiratory reserves. We can avoid thiopentone because it decreases hepatic blood flow. Etomidate is also so. There are different controversies related to that. What we follow, if there is a borderline hemodynamics, we use ketamine plus propofol combination. We give separately because ketamine has intrinsic sympathomimetic activity. So slow and titrated dose is a crux of induction. Maintenance, if it is an emergency situation, like patient is in perforation peritonitis, so we can give rapid sequence induction with succinylcholine, we can give it safely. But if it is non-emergency condition, if it's a planned procedure, then we should directly go for cis-atracurium, which we are using. Atracurium also will do if cis-atracurium is not available. Vacurinium and pancurinium we are avoiding because of different n number of reasons. Inhalational agent of choice, in our institute, we use sevoflurane or otherwise we are using isoflurane in cases of liver because they both have similar dynamics and they balance the hepatic arterial blood flow as well as portal circulation is controlled. Desflurane can be used, but it will not increase the hepatic blood flow. And in some cases, it may hamper the hepatic blood flow also. And if desflurane is also having a limited availability, it has environmental hazard. So in our institute, we are using sevoflurane or oblique isoflurane as far as availability is concerned in liver cases. We should avoid halothane, of course. Analgesia, opioids. So opioids are the good drugs. And nowadays we are getting remifentanil. So remifentanil is a drug of choice in liver cases. We are getting remifentanil now. We have started using it. But if it is not available, fentanyl as well as pentazocine will do. We have to avoid Morphine, we have to avoid sufentanil because they all will have a prolonged elimination half-life. Pentazocine can do because it has intrinsic sympathomimetic activity, so it can be used in limited titrated doses. But first choice will be remifentanil, second will be fentanyl, and third, if both are not available, then we can go for pentazocine. We have to avoid NSAIDs. Other modalities of regional technique, we are using epidurals if the surgeries are open cases, Whipples or some major GI surgeries. We are using PCA pumps also, or we are using intermittent boluses. We have various adjuvants. We can use buprenorphine along with local anesthetics. It is safer in epidural analgesia. Regional blocks we can try, TAB blocks, spiny blocks. Nowadays we are trying in some cases, but again we have to think of coagulopathy. So ultimately, managing the cases is full of challenges. So our post-operative outcome depends on perioperative concerns. So what are our perioperative concerns? If we not efficiently able to manage these cases, these patients may anytime land up in renal failure, hemodynamic compromise. There may be hypoxia, there may be DIC, there may be septic complications, or there may be surgical complications. So these concerns will affect our postoperative outcome. If patient lands up in hepatorenal failure, not expect good postoperative outcome. Similarly, if the recovery profile is not safe or smooth, again that will affect our postoperative outcome. So if patient is not hemodynamically stable at the time of extubation, if patient requires prolonged ventilation, if the ABG is abnormal, if the volume status is depleted, if electrolyte imbalance is there, or if patient is in sepsis, hematocrit is lost, there is severe blood loss, or CNS parameters are affected. If patient has landed up in hypothermia, there will be delayed recovery and it will affect our postoperative outcome. Generally, if the duration of surgery is more than 4 hours, if lot of hemodynamic fluctuation has already occurred, if multiple big incision is there, Whipple surgery is prolonged for 6 hours, so we keep them for elective ventilation for at least 24 hours, depending upon the conditions. So we keep them post-anesthesia care unit for 24 hours in ICU. You ventilate them prophylactically, and ultimately, then we extubate them on the next day, considering all the parameters. So this all depends upon our efficient management, and our postoperative outcome is directly affected due to this. A word about special circumstances. ERCP, again, it is kind of off-site location anesthesia. So it has its own challenges. There is sharing of airway with the endoscopist. Then there is limited accessibility to the patient. We cannot reach up to the patient easily in that ERCP room. It's off-site location. So we require special long circuits and everything. So the challenges are added over there. Patient is already maybe of obstructive jaundice, maybe of high severity of disease. And there we have to provide anesthesia. So it adds up to our challenges. Another thing, these patients may be posted for mild procedures, minor procedures, minimally invasive procedures. But we cannot consider them as small procedures or so, because the pathology of the disease itself is very big. It is a challenging case for us. So even for minimal invasive procedures, we have to take up the challenge completely. We have to do all the preparations. We have to maintain our entire emergency drug cart and everything we have to do. So for us, nothing is minor or something like that. For us, everything is major. And these patients have superimposed problems. So anytime these patients may land up in critical conditions. So these special circumstances, though they may be minor, but for us, they are always major. Some patients may be posted for emergency procedures. Now, this patient is having a long-standing alcoholic liver cirrhosis. He's 60 years old. He has 60% of parenchymal liver damage. All the bilirubin level, everything is altered. And now he's posted for perforation peritonitis. So one can imagine the gravity of the situation. On one side, we have the disease per se and its pathognomic features. And above that, this patient has landed up in perforation peritonitis. The problems of peritonitis, of the emergency, and of hemodynamic fluctuations are superimposed over that. So we will have to do rapid sequence induction. Our challenges will increase more and more. So these special circumstances are to be thought for. So ultimately, obstructive jaundice is a multi-systemic involvement. And it is a very hepatobiliary system involvement, but it involves multiple systems. To summarize, anesthesia for obstructive jaundice is a challenging case which solicits utmost efficiency, updated knowledge, and expertise. The modern anesthesia techniques, sophisticated gadgets, equipments, and advancements in the field of medicine has made achieving goals possible. One should stand with and promote the principles of safe anesthesia and standardized care. Thank you.